Hello, and welcome to today's 3M Health Information Systems webinar. My name is Ryan.
My name is Jared.
And we'll be your host today. We would just like to start off today by thanking everybody for joining us, especially in this time of great sensitivity in our country. There's a lot that we're facing, whether it's in healthcare or outside of healthcare. There's a lot unfortunately, there's a lot of turmoil that we're all facing. So we appreciate everybody joining in light of obviously the effects of COVID-19. Most of us are working from home today, so we appreciate your patience in understanding should there be any background noises or any technical issues. So please bear with us. We'll address anything that comes up as quickly as possible to try to optimize your experience. We know many of you in the past, recent webinars have had some issues. We've been addressing that with our webinar platform and doing everything we can to make it as good of an experience for you all as we can. And again, appreciate your patience and for you joining us today. Today's webinar, we'll be reviewing how you can enhance the impact of CDI with effective prioritization.
Great, and we encourage you to ask questions throughout the presentation. You can do this by using the questions feature in the web meeting controls, which is located in the lower right portion of your screen. We are recording today's presentation and a webinar archive will be available. So look out for an email within the next week that includes a link to the archive. Also, a PDF that contains all of the presentation slides is available for you to download, and that's located in the handout section of your web meeting controls. Lastly, we'll also provide a certificate of attendance to webinar attendees, and that will be emailed to you upon the completion of this webinar.
Thanks, Jared. Today's presenters are Julie Solomon, Diana Ortiz, Lynn Chipes, and I'll also be sharing a bit myself. So Julie is a Chief Product Owner for 3M CDI and Physician Solutions. She brings 34 years of nursing experience. She's worked heavily with a variety of hospitals, including small hospitals, large university and enterprise systems all across the nation. And Diana works for 3M Health Information Systems as well, helping to lead the revenue cycle team, and previously worked as a product owner for both CDI and HCCs. Prior to joining 3M, she was the director for ambulatory CDI at Ochsner Health System in New Orleans, Louisiana. Lynn is a health performance advisor here at 3M Health Information Systems. She has over 30 years of experience in health information management, and prior to joining 3M, she held positions as director of HIM and senior consultant and manager within the professional services and HIM software fields. As we dive into today's discussion, most of you are familiar with our quality webinars, and for the most part, our topics today, our topics are really focused on regulatory, operational, or clinical documentation issues that affect quality. And as we discuss today's topic of prioritization, it's really something that we've heard a lot of questions about from our customers, things that with limited resources, time and other constraints, CDI teams are looking, how do we maximize our impact? How do we avoid wasted time? How do we prioritize the right cases? So we want to address that topic today, not only addressing the challenge that many CDI programs face, but how do we as a 3M organization help you all to address prioritization, both from a services and a software standpoint. So we hope that what you find today is helpful. And as we dive into the topic of CDI, understanding the need for prioritization, we recently conducted some research with our customer base and found that CDI specialists are reviewing approximately 20 to 25 cases each day, but we found that only 35 to 45% of those actually have query opportunity. So we're finding that a lot of CDI teams, find challenges of truly being as effective as possible. They're facing high patient volumes, they've got limited time and limited resources. So getting to the right cases at the right time is a consistent challenge that we've heard across the industry. Further, as people have tried to address prioritization, this is kind of an infographic that we want to talk through. On the left-hand side, you see what we consider a blind case review or a manual review, taking the cases as they come. CDI reviews the chart. Oftentimes, though, those high opportunity cases end up being buried in the workload that they have. And then it ends up that many patients are discharged before they can ever be reviewed or have follow-up with the physician. So in our research, we found that 3.6 hours or less than half of the day was actually spent on cases with true opportunity. while over half the day, with 4.4 hours, were spent on cases with little to no impact. And what we found when people implement computer-assisted CDI, they can find much more efficiency in their work. The natural language processing allows them to drive transparent and customizable prioritization for both the health system level or facility level or teams or individual users, where they can prioritize based on specific DRGs, DRG opportunity. These are the types of things we're going to discuss today. But ultimately, as prioritization is effectively implemented in a CDI program, rather than splitting the day between valuable and less valuable case reviews, all 8 hours of the day are really focused on impactful case review. So we've also done some research with ACDIS. Most of you are probably familiar with the Association of Clinical Documentation Integrity Specialists. And in some recent research we did with them, we looked at how are people working to prioritize the initial CDI cases that are reviewed. That over half of them are prioritizing based on length of stay. Just over a quarter are using chief complaint or initial diagnoses. And what we found surprising and what we really want to address is that 20%, a fifth of all CDI programs weren't prioritizing at all. It's really first come, first serve, taking the top case or the case off the top of the work list. But for those who are, putting prioritization to work, looking at on the right hand side, you can see the various ways that they are prioritizing cases. So we'll talk through some ways that we found to be most effective in prioritization, both from again a software application standpoint, as well as assessing your own data and how services can support that. We found that as people do implement effective prioritization, as we said, rather than waiting until a patient is out of the hospital to realize that it's an important case to review, you can start reviews when patients enter the facility. You can expand that CDI coverage goals to include all payers rather than just focus on Medicare. You can look at Medicaid and commercial insurers. It improves your ability to address quality impact and meet financial goals by reviewing more cases with actual impact on reimbursement. Also, it expands the CDI program using the same number of staff, because we talked about limiting that amount of waste and reducing the time spent on non-impactful cases. In an organization that we've worked with closely to see this and who's seen great results from it is Kettering Health Network. If you look in that kind of gradient box there, overall, as they really focused in on the neurosurgery DRGs, they were able to find $2.6 million in annual benefit, which is incredible. When we look at, especially in today's, shrinking margins, not to mention the increasing challenge that we face with COVID-19, prioritization is crucial. And by doing effective prioritization and adding that to the bottom line, this is huge for hospital operations or health system operations. We also saw over an 11.5% increase in case mix index. Again, a major impact. And the changing in physician behavior in a lot of cases is the biggest impact that we can see, is helping those physicians to completely and accurately document their engagements. Ultimately, we like the comment that we heard from Kathleen Marchland, who is the manager of documentation excellence there at Kettering. She said, to comply with complex government regulation, you're required to have medical records, coding, and release of information departments. But CDI is not mandated by a governing body. CDI programs have to prove their worth, and 3M software for CDI worklist prioritization helped us do just that. So that really kind of sets the stage for why focus on prioritization and why are we talking about that today. So with that, I want to turn the time over to our experts. Julie, Lynn, why don't you kick us off and share how 3M can help with prioritization?
Thanks, Ryan. So Lynn and I today are going to talk about, kind of the behind the scenes thought process with, I'll represent the 360 platform, and how, we can marry that with the performance advisor services that Lynn provides to customers. And what we've tried to do, especially when it comes to the technology, is think about how can we, make it easier for the end user, for, the CDI team, other roles as well, like quality and coding, to get to the important cases, not, from a, NLU, clinically intelligent aspect, and pulling in the right kind of query opportunities, technologically, but also, what cases, as Ryan spoke to, what cases are important, what cases should I be seeing, what cases, should I let go? So how can I get to what I need to get to show my value and to show the true patient population that we're taking care of, as opposed to, busy time on cases that I'm not going to be able to really impact at all. We want to, of course, make sure that we paint that complete patient story concurrently while the case is in the house and not have to do a lot of back-end retro work. So, prioritization can help us. We can leverage that technology to really get to what we need to, the value, and of course have that complete story at the end of the day. So with the technology, we've tried to make it, no effort on the CDI's team's part. Bringing the cases that they find valuable to them is going to allow them to really do their work and not waste time, like Ryan showed, in a couple of those slides we just saw. So I'm going to represent how, we can use that and use the technological system to get to the right cases. And then, Lynn's going to show how, her piece can also influence what we're doing in, with the tool, with the 360 platform. So with that, I'll turn it to Lynn and she can talk a little bit about how we work together.
Thanks, Julie. In my role as a data advisor or coach, generally what I'm doing is I'm working with our 3M clients to analyze their data performance trends. Specifically, we're trying to focus on how their CDI program can help drive change within their organization. And what we do is we utilize that facility's post-discharge data for comparisons of performance against the national benchmarks. Julie?
Okay. So we're going to do a real quick poll question. We want to find out, what you all are doing. So, we know that there's a vast difference in how priority is happening across the country. So how do you guys prioritize your cases? Do you do that by length of stay, chief complaint, or initial diagnosis? You don't prioritize at all? Are you using software tools? If you're not, if it's not applicable, you can choose one of those selections that you see on the screen. And
okay, great.
We know. Oh, you got it already, Jared.
Yes, we'll give it just 5 more seconds here.
Okay.
Okay, closing it out.
This will allow us, to evolve, see how we can evolve. So I'll turn it to you, Jared, for the results.
Yes. So we had 22% say length of stay, 15% chief complaint, initial diagnosis, 15% don't prioritize, 27% software-based prioritization tool, and 22% not applicable or don't know.
Okay. So we can see that there's a variety, across the country of what folks are doing. And, there isn't a lot of commonality. Everyone's doing something a little different, but we do have blocks of customers that I work with that kind of do things around the same way. And I'll speak to some of that. And then we have others that maybe they don't have the same bandwidth to be able to, really, do what they'd like to do. So they have to start out in a different way. And we'll show some, different flavors of what we've seen with the customer base. All right. So of course, I think that everyone could agree that being able to get to really high priority cases is really going to help us get to those patient cases that maybe have something missing that would impact how they look from a quality perspective on the back end. A lot of times, those additional diagnoses that we're clarifying and adding to a case are going to impact the severity and risk of mortality for the case. So there, anything that we're collecting or querying on, of course, is going to have a big impact. The days of, really looking for CCs and MCCs are long gone. Financial is very important, We have to get paid at the end of the day. However, we need to make sure that we're also collecting on the back end those things that may be an underlying condition that would exclude us out of a quality penalty. So we're going to pay more on the back end, for CCs and MCCs that we pick up that maybe impact a PSI or a hack. And so we need to make sure that we capture that true story of the case and get the underlying picture of the patient. So really making sure that we can utilize all aspects of the case and think about the big picture and not just the financial picture. If we can chase the quality, of course, that's going to help the case overall. So, many of you are probably familiar with 360 prioritization. You may be familiar with this deck. What we've tried to do and with our development teams, and I have been in the industry for a long time, so I know kind of what we need to be doing, what we're looking for. How can we do that effectively? So we, with CDI Engage 1 plus 360 Encompass, we have the clinical intelligence and the picture of that clinical information coming in to the case. And then with the 360 priority that we've had for some time, we have the end user. No longer relying on the black box of a follow-up, like I'm going to go in every 2 days and rotely review and hope I find something. Now I'm going to use my priority factors, including that clinical content, to really leverage priority and get to the cases that I want to impact. So with the model, we have an auto-suggested DRG that is currently in a statistical model. That's our latest model that we can utilize not just for surfacing the auto-suggested working DRG before we see the case. That is absolutely a very big advantage when we're looking for the DRG bucket or category that the case falls in. That's going to help us kind of know what that case is from the start. We also can utilize the engine to surface something different in a case. So we have a new auto-suggested DRG priority factor that looks at the original auto-suggested working DRG, compares it to the end user's working DRGs, and will surface if it finds something different. So it kind of gives you a heads up of, let's get another look at, this DRG information. The system always, with the auto-suggested DRG, it always shows you all the options. What did the engine consider before it arrived at the final selection? The engine does a very good job. It's still an engine and not a intelligent human being, so it does occasionally get it wrong, but it shows you all the options. So and again, to me, this is like the Cliff Note version of what codes were considered on this case that the engine looked at. So it's kind of like the Cliff Note. Really helpful if you have a really long length of stay case. And then we can harness that auto-suggested functionality and really really crank up the population of our 360 work list. So, part of the problem with CDI review is we have to, in the old days, we had to get through a lot of cases that we really didn't care about seeing to get to the important cases. We didn't know what we were looking at. We couldn't queue them up, in any kind of order. So with the auto-suggested feature, if you turn that on, you can use those auto-suggested codes to pre-populate work lists for, focus areas or specific topics. So you can see here that I've got a CDI priority work list. I have several other work lists that I've created. There are 3 that you see there for COVID-19 that we created. What do we want to do? We want to collect all those COVID cases in the same, area, so I know where they are. They could be scattered across my house. And I don't know if they're COVID or not, but with this work list capability, we can pull them all to one place. It brings all the information with it. You know where they are in the hospital. You know if they had a mechanical vent. We can also do, COVID exposures. We could use sign and symptom codes that go along with COVID that may not be formally diagnosed, but it could give us a heads up if, we need to take a look at those cases if potentially they could be COVID, such as, diarrhea. Those types of symptomology that we're now finding is related and linked to COVID that initially folks weren't expecting. We also can create a query escalated workflow, and you can see that you can also use these work lists for second level review and denials. We recently created some work lists for a customer around estate mortality and morbidity reporting for maternal cases. So there's a lot of flexibility, and it really helps you leverage and smartly, review your cases. And then we can also leverage length of stay, and that's something that came up in our poll. Customers really do want to leverage length of stay. We have several ways to do that by if it's an elective surgical or medical case, maybe we don't ever want to see it until it reaches a certain length of stay. Then we also can want to surface folks that have are getting close to exceeding their length of stay, or they're in a low SOI and ROM and they're getting close to exceeding or have exceeded their length of stay. So being able to surface certain DRGs is really important. So here we've got a good example of a patient with a TIA who has exceeded their length of stay, and you can also see that robust clinical conditions that are coming into that to create the score for that priority factor. So again, we've got that robust clinical intelligence as well as the end user piece. So, I've got a couple examples here of cases that are going to dovetail into what, Lynn is going to share. And from her perspective, going into that data and finding those areas where, customers have opportunity can really help us drive, what you're going to be able to leverage with the technology. And with that, I'll turn it to you, Lynn.
Thank you, Julie. So from the standpoint of looking at performance data monitoring and comparing that to 360 and Compass, really the key differences in performance data monitoring and 360 is truly the data and reporting utilization. Within 360, the CDIs, they're going to utilize that data and reporting for their day-to-day operations, and they have access to that current and abstracted data that resides within 360. However, within PDM, we're utilizing that coded claims data that comes in post-discharge from our facilities. And what that allows us to do is to look at that data as a whole and then specifically focus on the CDI impact to their organization's data. And the data that is produced within PDM, that is available in a PowerPoint presentation, and it's also available in our online portal. In our online portal, we refer to that as PDM 2.0, and that has several components. What I want to start off by showing is what we call the executive dashboard, and it's a high-level overview of a lot of the data that we show within our data monitoring PowerPoint reports. But within this online portal, what we're doing is we're providing clients, again, with that high-level executive dashboard where you can easily track some of your performance metrics. And again, it mirrors a lot of the information that's in our PowerPoint reports. And we're showing you a sample data set. And within that sample data set, what we can do is we can easily identify the specific service lines. You can see at the top where we show medical versus surgical opportunity. We can show you the ones that have that greatest opportunity. Okay. And then down at the bottom, you can see where it says top pairs with opportunity, top clusters with opportunity for surgical as well as medical. So we really do take it another step further and provide details on those top DRGs within those service lines with financial opportunity. And we're comparing that against a best practice measurement. So again, it's showing you, that detail behind the scenes that goes into those particular service lines. On this slide, we're really looking at our compare report, and that's really the real strength, I think, of our 3M PDM online portal is the ability to drill down into cases. So on the previous slide where we could see some of that potential opportunity within some of our key DRG pairs, in triplets with opportunity, what we can then do is take that information and then drill down into PDM, and we can get down to that patient level detail. So the top right box is where we're showing you, where you can see where that opportunity lies. And for this example, you can see the box where it's showing, your heart failure. So we're specifically looking at that triplet, and we're looking at those cases that did not have an MCC or CC. So you can see there are 11 of those cases. So what our PDM platform allows us to do is to drill down into those 11 cases, and that's where my job as a data coach or data advisor, I'm coaching our clients on. Once you download that data, we really want to try to isolate those length of stay outliers. We can sort and do a longest to shortest length of stay, and then go in and start to analyze that data. Our data monitoring clients, they receive our reports, and it's on a varying reporting frequency. It could be monthly, it could be quarterly. Again, it's in a PowerPoint form. So we take the information within our raw data reports and we analyze it for our clients, and we're trying to surface up where we find those MCC and CC opportunities. And we look at that from a medical and a surgical standpoint. So again, we're showing you sample data. So what we're doing is we're looking at that facility's capture rate, comparing that to what is considered to be the best practice. And then again, what we're trying to do is to drill deeper and deeper into that data, looking at the length of stay comparisons for the facility as well as compared to, whatever that best practice may be. We also want to consider what impact those short stays or those 1 and 2 day length of stays is having on that data. So we're taking different data points, pulling it all together so you can see where those opportunities may be. Down in the surgical side of things, I boxed up the major joints, the 469, 470. Okay, that's not typically one that we are going to tell a client to focus on, because we know those are generally elective type of cases. They're in and out. But Julie's going to take a little step further, and show how you can use the length of stay factors to focus on this one. So really what I would coach a client on is I'd say we really want to focus on those 204 cases. And we can see that this facility is running a shorter length of stay compared to MedPAR. And again, MedPAR length of stay for a 470 is 2.5 days. So we would want to drill down into that data using PDM 2.0. And once we do that, one of the biggest things we coach our clients on, again, is to let's sequence those cases from the longest to the shortest length of stays, because again, we really want to focus on those with the longest length of stays. And what I like about this is right up against our discharge disposition, so we can look to see, was it, maybe was the length of stay longer because they were waiting on a nursing home placement. For this sample set, we can say they are all discharged to home, and we see a couple with a length of stay of 8. So those would definitely be ones that we would want to focus on. Okay, Julie, I'm going to hand it back to you.
Okay. So Lynn gave a nice overview of, the historical data that they look at. So it's the data drop, and, being able to look at your data in the current year you're in and compare back to the previous year gives you a lot of, good detailed info as to where your real focus areas are from a lot of aspects. So then, the listing part of that function is once you go into PDM and you look at those cases and you see the commonalities, maybe you determine, what kind of, unspecified diagnoses were on those cases that might have added to, the picture of that case. Did we have something that was undefined that, really didn't, pop up as it should in the data, didn't get spelled out? How do we go in and find those cases, and how do we educate our physicians? That's going to be something that's very important, and we can do that with that view of what's already happened. But then how do we, leverage that to be able to put that into play on a concurrent basis so that we're not having to go back and try to educate our physicians, but we can take action right in the midst of the case and up front. And, we can leverage the technology to help us do that. So I have a sample work list. This is around length of stay for some of the examples that Lynn had in her data. And you can see that I've got a 470 at the top there that I am going to leverage a couple ways. So what I can do in 360 is I can go into that DRG 470 and I can specifically map it to that elective surgery category. for, the D or G categories that we have in priority. But then I can also take it one step further, and I can apply any of the other length of stay factors that either just exceed the length of stay, or I can make it surface those that, are in a SOI of, of 2. So we've got some good flexibility. I can count down. So it's going to help me leverage a lot of these others. So if I have something that doesn't belong in an elective category, for medical or surgical, then I have the ability to let that DRG stay in the category that it belongs in. So if I'm a surgical case without a CC or without an MCC or any of those, I stay in the appropriate category, but I can apply those length of stay factors to be able to populate when it gets close to that. And you can see that I've got several different case types here on the screen with infectious disease, GI hemorrhage, we've got intracranial hemorrhage, so a flavor of different opportunities that Lynn shared with us. So in looking at these opportunities, this one is that 470. You can see that the factor for the length of stay category fired. I can, go right into this case, and what I can do is populate those work lists like I showed you before. I can have this, up on the priority work list come to the top, and I will have that heads up that, oh, this is still here, or it's going to be here longer than it should, and you need to take a look at it. So you're going to get notice that that important case is at the top of your list. And, even moving one or two of these, joint cases to show that true picture is going to really impact, from all aspects, from CMI to SOI to ROM, et cetera. So this one is an example of, a sepsis case that doesn't have an MCC. And again, it's exceeding its length of stay. Why is it still here? So no longer do I have to hunt through, and find these cases. They're going to surface for me. So it's part of, going in and setting up that DRG to fire and show up when you want it to. You can see that there are other factors that are also on the case that's going to help it climb to the top and show the value and importance for that particular case. And so all of these, this one lets you, really see the two of the factors, the length of stay exceeded and length of stay exceeded with the SOI and ROM plugged in as well. So, when we marry the PDM and 360 together, we can now take those, those areas where Lynn has told you you have opportunity, and we can leverage those, showing up without you having to go and manually find them. Look at the cases, look to see what's specified or unspecified, and rely on, that manual education to the physicians to leverage those cases. The technology will bring it right to you from that length of stay perspective. And then when you add that in to the other functionality with the clinical conditions, and we're going to talk a little bit about that on this page. So bringing in that opportunity. If I have an opportunity for a potential condition, you can see there are two different flavors in 360. We have the content that we had in the system prior to our M-Modal acquisition, and you can see all that here. And then we have the NLU, Natural Language Understanding content, that is a new offering that has over 400 rules in it. The rules are flexible and customizable, and you can see the different topics. So when you add that clinical intelligence, into the priority, it does really bring it up a notch and allows you to have the whole clinical picture and the end user picture all at once. So, what we've seen across the country best practice wise is, really, looking at, getting a super user group together to make sure that your workflow is matched in the technology workflow, being able to at any time make adjustments to it, not relying on the 3M to help you, looking at Lynn's data and that robust data if you have PDM, and then surfacing that in 360 really makes for a complete picture with priority. So those, two nice complements. There are, many ways to leverage beyond length of stay. We kind of showed that today. This slide kind of shows you that best practice report card. So I've listed several of the other priority factors, the ability, to do query escalation, to use those potential conditions, using the software in the intended workflow so those factors dismiss naturally, and really being able to get that record complete prior to discharge. So across the country, we've seen customers do the best practice workflow that you see on the left. We have some customers that maybe, it's a whole different mindset. They're going to ease into it. They might do the majority of priority, but they're not doing, the entire thing the way we would recommend. They still see a positive impact. They're not going to see the full impact as the best practice customers, but certainly, it's well worth it. So, where do you stand in your priority? And where do you want to move to? Getting to that evolution of maybe you need to start with some baby steps, but then the goal is to get up to the level of functionality that's going to help you surface and focus in on the data that you need to. And with that, I'll pass it to Lynn, and she can talk about, we can really, do a good job in marrying the two pieces together to get the ultimate prioritization.
Thank you, Julie. What we find is, you can see on this graphic, when you think about a program initiation and those initial improvements that you see, usually when you get several years into your program, after some time, you start to hit that plateau. So what we find is that between the combination of data and coaching, that gives our clients the information they need to manage that program, because we want that ongoing improvement. We want our clients to continue on that path over time, to give you those tools to help you drill down into, find those specific areas of focus. We want that continued opportunity. And so just keep in mind that our PDM reports really complement what you're getting out of the 360 standpoint, and those PDM reports really help you track and trend those CD opportunities across all of the cases. So we want to continue to fine tune that focus so you don't plateau and you continue to have that steady pace of improvement.
Thank you both. So just to give a little bit of an update on some of our customer success, and then we have just a few slides to share with you on this. So this is an organization that we partnered with that implemented prioritization. One of their main goals around it was to have quality improvement. So in order to be able to expand their CDI team to support quality initiatives, they really needed to make sure, like has been stated here, that they were spending time on the right cases and weren't missing out on any revenue opportunities. As you can see here, from March to December, so a good amount of time, they were able to see that revenue CDI, the revenue associated with CDI review pretty drastically increased by month. They saw improvements in their CMI in both medical and surgical. Like Julie mentioned earlier, the customization and the ability to kind of set up for whatever issue it is that your organization is kind of challenged or tasked with. Denials is a big important one. So if there are certain DRGs that you see coming across, that are common for denials, respiratories, sepsis, malnutrition, if there are particular diagnosis level even. So those are things that you can set as a priority. Like in our organization, we don't want to miss any of these. We want all of them reviewed second, third time if needed to really mitigate all of that back end work that can come from a denial situation. So here you can see their sepsis denials drastically went down, right? They're spending time on the cases that make sense to them and to help kind of fight those battles that they might be up against. Some top 10 DRGs, so they got to see some kind of shift in focus. Again, going back to some of the data that you can dive into, like Lynn was covering, you could certainly change those focuses over time depending on where you are at with your MedPAR comparisons. So again, before that, like I said, they had really no HAC or PSI, task force or anything around that. Now they're able to start to look at those and have their CDI teams expand and to help their organization with those challenges. So with that, let me just click to the next one here. I will pass it over to Ryan to talk about some successes with the services.
Thanks, Diana. Yeah, as we looked at kind of the benefit and the impact of customers who used our performance advisory services, we looked at a sample set in aggregate, and that's what is demonstrated here. So really, we broke down this large group of our customer organizations by facilities and plotted them by number of years that they've been using performance data monitoring data, as Lynn described. You can see that, with increasing years, the average cumulative CMI continued to increase. Lynn talked about avoiding that plateau, and this shows that impact of CDI review continued to increase with the leveraging the performance data monitoring data as part of their CDI program. We see when we talk about ROI, we see the improvement that increases year over year, and the average cumulative financial impact, again, increasing year over year. So the idea, and I think the key takeaway here, is with proper prioritization, with the assistance of external coaches with the expertise, that plateau doesn't have to happen. The continued progress and increase is possible and potential for you. So again, hopefully this is informative to you as far as what you could look for in your CDI program's impact.
Thanks, Ryan. We have a short video here that is a testimonial. So give me 1 second and I'll go ahead and share that with the audience.
We wanted to make sure that our staff was working smarter and not harder, and getting opportunities to improve our physician documentation. 3M helped us identify an opportunity with neurosurgery to really make a difference in our CC-MCC capture rate. Those surgeons tend to not document very well quickly and just focus on the problem that they're maybe doing the surgery for the patient and not the other diagnoses that may exist for the patients.
Prioritization work list allowed them to sort their workflow by the number one thing that we were working on for an improvement process, which became the neurosurgery DRGs. We had a CC-MCC capture rate that was very low against our peers, our 3M peers, plus the state of Ohio data. And it was a window of opportunity for us to speak one-on-one with those providers because they were engaging and gave us the opportunity to come to their service line meetings and teach documentation excellence, and then prioritize our work list, so we started there.
So implementing the prioritization, we actually saw a positive increase in our CC-MCC capture rate in as little as 3 months, and we've continued that. It's probably been about 9 months in total, and it's done nothing but get better over that time.
Post-prioritization work list, we submitted, after 3 months, it was about 266 cases that showed a case mix index increase of 0.419, which equated to about $800,000. Had we applied that formula to the previous 12 months prior, it equaled about $2.4 million increase that we would have obtained had we used it prior.
Actually, 3M, first of all, identified this opportunity for us and then helped us work together to make sure that we had our data accurate and to show that the changes that we made made a statistical difference for us. They also helped us get everything all set up and made sure that we knew how we were going to train our staff. So actually 3M's been a great partner through this process. The next big hurdle is continuing this process and identifying where our next opportunity is.
We're trying to get the phone to stop ringing. Lots of service lines are calling because they've heard about it. Our executives have celebrated our neurosurgery wins. There's been lots of shout out announcements at the executive level. So other service lines are knocking on the door.
Yeah, so that's a great story. We have several other stories here I just wanted to kind of highlight. As you think about your CDI team and the real challenges like they faced with trying to keep up Certainly, this leveraging work list prioritization is certainly a way to help expand your team. If your team wants to get into PSIs and hacks, as you can see down here, they're able to now leverage the tool to identify those and really prioritize how important those as well as other cases are for their organization. I just go back to Ryan sharing those statistics in the beginning. You can only do so much on cases, right? And there are certain cases that are just, not going to provide a lot of value for a CDI team member to spend their time on. So looking at some of these other health systems here, as you start to look at getting into outpatient or getting into data and quality indicators that you couldn't get to before, certainly leveraging a prioritization tool can help with that, right? Spend your time where it gives you the biggest value.
Thanks, Diana. Jared, let's go ahead and jump into the Q&A section of the webinar.
Yeah, absolutely. So if you'd like to submit a question, you can use the questions feature in your web meeting controls, and that's located in the lower right corner of your screen. And just let's go to the next slide there, Ryan.
You bet. Slight delay. There we go.
There we go. Okay. So yeah, if you'd like any more information about the topics here, go ahead and select your top interest, and I'll go ahead and launch that poll. And while that is coming through, just a couple of reminders that there's a PDF. It contains all the presentation slides that's available for you to download. That's located in the handout section of your web meeting controls. We also recorded today's presentation, and a webinar archive will be available. So look out for an email from the next week that includes a link to the archive. Lastly, we'll also provide a certificate of attendance to webinar attendees, and that will be emailed to you upon the completion of this webinar within the next hour or so. Okay, I'm going to go ahead and close out that poll. Just give it about 5 more seconds here. Okay, and Ryan, if you want to go to the next slide there.
Yep.
One more.
Here we are. Yeah, I wanted to make sure that everybody, especially you as 3M customers, are aware. Most of you are aware of our 3M Client Experience Summit that we love to have every year. We typically have it in person in Salt Lake, and while we're disappointed to not be able to do that this year, obviously with the impact of COVID-19, that in-person meeting is not feasible. We are excited that we're having a virtual meeting. It'll be the same dates, July 27th through the 31st. And one of the benefits is that, a lot of people who have wanted to come out to the Client Experience Summit and historically haven't been able to due to, travel constraints, budget constraints, that's no longer a barrier. So we're excited that we can expand our audience this year with a virtual meeting. You can see at the bottom there's a rather lengthy link where you can go in and register. You can download the agenda. Don't worry about copying that down. You'll actually be able to click into that in the version that you've been able to download, the PDF that you have on the right-hand side of your control panel. So click into that. You'll be able to go in and register. And we look forward to having everybody, again, all of you who are 3M customers, join us at the 3M Client Experience Summit next month. With that, I think we are, let's see, Jared, have we got any questions come in?
Yeah, it looks like we got a couple of questions here that we can go over here. So the first question, do you review these LOS outliers the day after discharge but before final billing? Just trying to understand the workflow our CDI group works concurrently.
Can you repeat that? Or Jared?
Yeah, yep, I can repeat that. Do you review these LOS outliers the day after discharge but before final billing? Just trying to understand the workflow our CDI group works concurrently.
Okay, so I guess without the background of kind of the detail around what is happening today, what I would probably recommend is, if we have a particular group of cases that we look for that commonality or, the outliers in those DRGs. And then it's pretty easy to go into the system and set up the length of stay, factors for that particular DRG. One thing that I may not have mentioned is that's all, customizable at the DRG level. So, you go based on your internal length of stay that you see and what you see those patients moving past. When do you want to touch the case? So setting up the methodology so it gives you the number of days that the patient will get to before you get your heads up. So it's very customizable as to when you want to touch it. So that helps us get to the case prior to that code set being dropped or the patient being discharged. And so we're not holding things up on the back end, and we can kind of get a heads up about those outliers right away. And, the goal, of course, is to get everything as concurrent as possible so that we reduce a lot of that back end, heavy lift that we see today with trying to, we have to redrop a bill, which creates problems, trying to do that pre-bill review. We can marry up that pre-bill review with our concurrent workflow and reduce a lot of that back end work.
Yeah, and I'll just add to that, Julie. So those work lists that we showed on here, those are concurrent work lists. It's
That's
definitely
correct.
Taking the data that's coming from what Lynn had showed is post-discharge data, but it's looking for those trends and then operationalizing them in a concurrent work list. So yes, it is absolutely a concurrent CDI workflow.
Yeah, and just to speak one more piece of that is, the work list that I showed that we're, really utilizing that auto-suggested code functionality. So what you can do is you can create that a special work list if you need it. If you've got a real focused area, all you need to do is leverage the auto-suggested code to, pre-build that work list before an end user touches the case. It's going to just gather all of them in one place. So if we got sepsis denials, it's going to gather all of those cases together based on DRG or diagnosis codes or procedure codes. So, it really leverages and the end user doesn't have to go hunt and find.
Awesome.
Great. Okay,
Thanks, Julie.
thank you. Oh, go ahead, Ryan.
Thanks, Jared. No, we've appreciated everybody's participation. We do have to wrap just a little bit early today, but we, again, appreciate everybody's attendance, everybody's participation. Thank you, Julie. Thank you, Lynn and Diana. Thanks, Jared. It's been a great presentation. Hopefully everybody found it informative. Again, we hope everybody is well and continues to, hopefully we're all seeing some progress as we continue to battle the challenge that COVID-19 is. It's kind of the ever-present topic of conversation, but we hope that there's a light at the end of the tunnel for everybody and that we continue seeing progress. We appreciate, again, everybody joining, and I hope you all have a great day and a great week. Thanks and take care. That wraps our 3M Health Information Systems quality webinar for today.